All right, get ready for this one because we're wrapping up this integrated pharmacotherapy for pharmacology series with Dr. Shorbegi.
We are.
And he's, saved some pretty hard-hitting topics for last pancreatitis and viral hepatitis.
Right.
These are conditions that impact millions worldwide.
Yes.
And we're going to uncover all the need-to-know info from those classic symptoms to the latest treatment breakthroughs. So
what I think is fascinating here is that we're not just talking about modern medicine.
Right.
Dr. Shorbegi takes us way back in these lectures. He even points out that hepatitis was documented as far back as 500 BC.
Wow.
In Babylonia. So
that's incredible.
Yeah, so they were grappling with jaundice thousands of years ago. It's amazing.
That really puts things in perspective, doesn't it?
It does.
Okay, so let's unpack all of this, starting with pancreatitis. What exactly is pancreatitis, and what's the difference between the acute and chronic forms?
So pancreatitis is essentially inflammation of the pancreas. And this is an organ that's tucked away behind your stomach, and it's vital for digestion.
Right.
So, we often don't think about it much, but it's very important.
Right.
Now, acute pancreatitis is when those powerful digestive enzymes, and they're supposed to be breaking down your food, instead they kind of go rogue and attack the pancreas itself. So think of it as like a sudden explosion in the pancreas. But the good news is, with the right treatment, the pancreas can often bounce back.
Oh, okay. So it's like a temporary system crash.
Exactly.
Okay.
Now, chronic pancreatitis, this is more of a slow burn. It's ongoing inflammation that leads to permanent damage, scarring, and that leads to a decline in the pancreas' ability to do its job.
Okay, that sounds pretty rough. So what are some of the culprits behind this pancreatic pandemonium?
Yeah.
Like what triggers this explosion in the first place?
Yeah. Dr. Shorbegi gives us this really handy mnemonic to remember the causes, and it's bad hits.
Bad hits. That sounds more like a bad night out than a medical condition.
It does, right.
So break it down for me. What does bad hits stand for?
So each letter points to a potential trigger. So we've got problems in the biliary tract, like gallstones that might be blocking the flow of digestive juices. So that's the B. Then we've got A for alcohol, which is a major player in many pancreatitis cases.
Right, deformed.
And then D represents drugs, including certain steroids and diuretics. That can also stir up trouble in the pancreas.
Oh, wow. So it's not just, lifestyle choices. Medications can also be a factor.
Yes.
What about those hits?
Okay. So H stands for two conditions. Hypertriglyceridemia, which is high levels of fats in the blood, and then hypercalcemia, which is high calcium levels. And then the I is for idiopathic, which basically means we don't know the cause.
Right.
It's kind of a medical mystery.
There's always a bit of mystery in medicine, isn't there?
There is.
All right, so T and S, don't leave me hanging.
Okay. So T stands for trauma, and this could be an injury during surgery or a direct blow to the abdomen. And get this, S stands for scorpion stings.
Scorpion stings? You're telling me something as tiny as a scorpion can set off this intense inflammation of the pancreas?
Yeah. It just goes to show how diverse the triggers can be and how sensitive this organ is.
Incredible. Okay, so let's say someone's been hit with one of these bad hits, and now they're in the throes of acute pancreatitis. What does that actually feel like?
Oh, it's not pleasant. So the hallmark symptom is this sudden, severe, unrelenting pain in the upper abdomen. And we're not talking about just mild discomfort here. This pain can be very intense, radiating to the back. And often it's accompanied by nausea, vomiting, loss of appetite, fever. In rare cases, you might even see bruising around the flanks or the belly button.
Wow, a bruise is a symptom of a pancreatic problem.
Yeah, it's pretty wild.
That is wild. So how do doctors even diagnose acute pancreatitis?
So blood tests are going to be crucial. They're going to be checking for elevated levels of amylase and lipase. These are two enzymes that go through the roof when the pancreas is inflamed. Imaging plays a role too, so a simple chest x-ray can help rule out other conditions, and then an abdominal ultrasound provides a direct look at the pancreas. If they need more detail, they can do a CT scan or an MRI.
Okay. And Dr. Shorbegi also mentions a procedure called ERCP.
Yes.
It sounds pretty intense.
It does sound intimidating, but ERCP, or endoscopic retrograde cholangiopancreatography, is actually a very useful tool. So picture this. A long, flexible tube with a camera on the end is threaded down the throat, through the esophagus, and into the small intestine.
Oh, wow.
And this allows doctors to visualize the pancreatic and bile ducts, pinpoint blockages, and even remove gallstones if those are the culprit.
Wow, that's some serious internal exploration. Okay, so once they figured out that it is acute pancreatitis, How do they put out the fire, so to speak?
Well, it's all about a multi-pronged approach. Supporting the body while it heals, taming the inflammation, keeping infection at bay, and tackling the root cause whenever possible.
So what does that look like in practice? What are the actual treatments?
Well, first and foremost, you've got to manage that excruciating pain. Strong painkillers like pethidine are essential. And then, since nausea and vomiting are so common, antiemetics can provide some much-needed relief. And to give the pancreas a break, doctors might recommend going NPO for a few days. That's nil per os, meaning nothing by mouth.
Oh, no, okay. So just let the pancreas rest and recover.
Exactly.
Got it.
Medications like omeprazole or ranitidine can help reduce stomach acid production, which can further irritate the pancreas. And in some cases, doctors might use anti-secretory drugs like somatostatin or octreotide to kind of dial down the production of those unruly pancreatic enzymes.
Okay, so it's like hitting the pause button on enzyme production.
Right, exactly.
Right.
So it's kind of like a multi-pronged approach, hitting the problem from different angles.
Yeah. What about antibiotics? Are those routinely used in acute pancreatitis cases?
Not always. Antibiotics are usually reserved for situations where there's clear evidence of infection. Sometimes they'll even use a needle aspiration to sample any necrotic material and confirm the presence of bacteria.
So it's a targeted approach, using antibiotics only when absolutely necessary.
Right.
Okay. What about fluids? I know those are crucial in many medical situations.
Oh, absolutely. So aggressive fluid rehydration through IV fluids is vital, and this helps maintain blood volume, support organ function, and aids in flushing out toxins.
Okay, that makes sense. So we've covered the acute side of things. Let's shift gears now and talk about chronic pancreatitis. We know it involves permanent damage. What are the long-term consequences for someone living with this condition?
Yeah. Chronic pancreatitis can be quite a challenging condition to live with, so that ongoing inflammation and scarring that slowly chips away at the pancreas' ability to produce those digestive enzymes and essential hormones like insulin.
Oh, wow. So their digestion takes a major hit.
Yes, and that can lead to a whole cascade of unpleasant symptoms. Persistent abdominal pain, diarrhea, fatty stools that are difficult to flush, nausea, vomiting, even shortness of breath. It can be incredibly disruptive.
Wow. And Dr. Shorvagy's slides show how these digestive issues can lead to unexplained weight loss, excessive thirst and fatigue, and even diabetes if the pancreas can no longer produce enough insulin.
Yeah, exactly. It's like a domino effect with one problem leading to another.
So what can be done to help someone manage chronic pancreatitis? Is there any way to kind of turn things around?
Unfortunately, with chronic pancreatitis, the damage is permanent. So the focus shifts from curing to managing symptoms, improving quality of life, and preventing further damage.
Okay.
Pain management remains a top priority, and doctors often prescribe strong painkillers to provide relief.
Right. So what about those digestive problems? Is there anything that can help with those?
Here's where it gets interesting. Since the pancreas isn't churning out enough digestive enzymes, doctors can actually prescribe artificial digestive enzymes.
Oh, okay. So we're essentially replacing what the body is no longer making.
Yes. And if diabetes develops as a complication, then insulin therapy steps in to regulate blood sugar levels.
Right. So it's about addressing each symptom and complication as it arises and providing support where the body needs it.
Yes.
Okay. What about steroids? I know those are powerful anti-inflammatory drugs. Do they have a role in treating chronic pancreatitis?
They do, but in a very specific situation. So steroids are typically reserved for cases of autoimmune pancreatitis, where the body's own immune system is mistakenly attacking the pancreas.
Gotcha. It seems like there's a lot to consider when managing chronic pancreatitis. It's not just one treatment, but a whole toolbox of options depending on the individual's needs.
Absolutely. It's all about personalized medicine, tailoring the treatment plan to each patient's unique circumstances.
Okay, so we've covered a lot of ground on pancreatitis.
We have.
Ready to move on to the viral hepatitis portion of Dr. Shorbagy's lecture.
Let's dive into the world of viruses.
All right, so before we get into the specifics of each type, can you give us a quick overview of what viral hepatitis actually is?
Yeah, so viral hepatitis, as the name suggests, is inflammation of the liver caused by a viral infection. And just like pancreatitis, there are different types of viral hepatitis, each with its own unique characteristics and challenges.
Right. Now, you mentioned earlier that hepatitis has been around for centuries.
Yeah.
How far back does our knowledge of these viruses actually go?
Yeah. This is fascinating. Dr. Shorbagy points out that we have written accounts of jaundice, which is a telltale sign of hepatitis, dating back to 500 BC in Babylonia.
Wow.
And even Hippocrates himself described what he called epidemic jaundice back in 400 BC.
Wow, those are some ancient medical records.
They are.
So let's talk about the different players in this viral world. We know there's hepatitis A, B, C, D, and E. What are some of the common features that they all share?
One of the interesting aspects of viral hepatitis is how it unfolds in stages.
Okay.
So Dr. Shorbagi, he calls them the prodromal, the preicteric, the icteric, and the convalescent phases. So it's like the virus takes you on a journey, and each phase is marked by different symptoms.
Okay, so take us through this viral journey. What happens in each of these phases?
It happens about 2 to 3 weeks before the classic jaundice appears. And during this phase, the virus is starting to make its presence known, but in subtle ways. So you might have some joint pain, skin rashes, swelling, fever. It's like the virus is testing the waters.
Okay, so it's a bit of a stealth operation.
It is.
And then what happened?
Then comes the preicteric phase,
Okay.
where those gastrointestinal symptoms take center stage. So we're talking nausea, vomiting, abdominal pain, loss of appetite, even changes in taste and smell. And of course, you'll feel generally unwell, tired, achy, and that headache and fever from the previous phase might be lingering.
Okay, so it sounds like things are escalating.
Yeah.
And is this when the jaundice finally makes its appearance?
Yes, that's right. So the icteric phase is when the liver is really inflamed and that yellowing of the skin and eyes becomes visible. The good news is that the fever usually subsides during this phase, and some of the other symptoms might start to ease up a bit.
Oh, okay, so it's like the peak of the storm, and then things start to calm down.
Exactly.
Okay.
Finally, we have the convalescent phase where the body begins to heal. And this phase can last for several months, but most people make a full recovery within 6 months.
Okay, so that's the general progression.
Yeah.
But each hepatitis virus has its own personality, right?
Right.
What are some of the key differences between them?
Right. So they differ in several important ways. How they spread, how long they incubate in the body, their likelihood of causing severe liver damage, or becoming a chronic infection.
So that's a lot to keep track of. Is there a way to easily compare these differences?
Yeah, Dr. Shorbagi, being the organized genius that he is, he uses a table to break it all down.
Okay.
So it compares hepatitis A, B, C, D, and E side by side, looking at things like incubation period, transmission routes, risk of fulminant hepatitis, and likelihood of becoming chronic.
Okay, perfect. Let's walk through this table then. First up, incubation period. How long does each virus kind of lurk in the body before symptoms appear?
So hepatitis A is the quickest, with an average incubation period of 30 days.
Wow.
Hepatitis E is close behind at 40 days. Hepatitis B and C are in the middle of the pack, with incubation periods of 75 and 50 days, respectively.
Oh.
And then there's hepatitis D, which is kind of a wild card.
Wild card. What do you mean?
So hepatitis D is kind of sneaky. It can only infect people who are already infected with hepatitis B. It's like a parasite that needs a host to survive.
Okay.
And its incubation period is around 35 days.
Interesting. So how did these viruses actually spread? I know some are foodborne, others are bloodborne. Can you break that down for me?
Yeah, you got it. So hepatitis A and E are primarily transmitted through what's called the fecal-oral route, which means they can lurk in contaminated food or water. So think about poor sanitation or even something as simple as not washing your hands properly.
Right.
These are ways that these viruses can spread.
So hygiene is our first line of defense against those two.
Absolutely.
Okay. What about hepatitis B, C, and D?
So those are spread through blood and body fluids. So sharing needles, unprotected sex, or even getting a tattoo or piercing with unsterilized equipment can put you at risk.
Okay, got it. Avoid sharing needles, practice safe sex, and be picky about your tattoo artists.
Yes, exactly.
Now, I know that some types of hepatitis are more likely to cause serious complications than others. What's the deal with fulminant hepatitis?
Yeah, so fulminant hepatitis is a rare but life-threatening complication.
Okay.
So imagine the liver rapidly shutting down, unable to perform its vital functions. And this is most common with hepatitis D, especially in pregnant women, where the risk can be as high as 30%.
30%? That's terrifying. What about the other types?
Thankfully, the risk is much lower for hepatitis A, B, and C, less than 1% in each case, and hepatitis E very rarely causes this complication, except during pregnancy.
Wow. Okay. So hepatitis D is definitely one to be most wary of in terms of fulminant hepatitis.
Yeah.
What about the likelihood of developing chronic hepatitis? I know some of these viruses can stick around for a long time.
You're right. So chronic hepatitis is when the infection persists for more than 6 months. Now, hepatitis A and E, they're usually acute infections, meaning they run their course and then clear up. But hepatitis B, C, and D, those have a much higher tendency to become chronic.
How much higher are we talking?
Well, about 10% of people with hepatitis B will develop a chronic infection. For hepatitis C, it's a whopping 85%.
Oh, wow.
And if you happen to get infected with both hepatitis B and D, that risk jumps to almost 90%.
Wow, those are some sobering statistics. So clearly, preventing these infections in the first place is crucial. Let's talk about management strategies. What can we do to protect ourselves from these viruses?
Vaccination is our strongest weapon, but unfortunately, it's not available for all types of hepatitis.
Right, so which ones can we get vaccinated against?
We have highly effective vaccines for hepatitis A and B.
Oh, that's great news. So tell me more about the hepatitis A vaccine.
So the hepatitis A vaccine, it's got brand names like Havrix or Vocta, and it contains inactivated or killed hepatitis A virus.
So there's no chance of actually getting infected from the vaccine itself?
Exactly.
Oh,
It's completely safe.
okay. And how effective is it?
It's incredibly effective, especially after 2 doses.
Fantastic. So who should get the hepatitis A vaccine?
It's recommended for travelers heading to regions where hepatitis A is common, people who use illegal drugs, and researchers who work with the virus.
Okay, that makes sense. What about the hepatitis B vaccine? What's in that one?
So the hepatitis B vaccine, like Energix B or Recombivax HB, contains a harmless piece of the hepatitis B surface antigen. It's like showing the body a mugshot of the virus without the actual criminal present.
Ah, so it tricks the body into thinking it's been infected and mounts an immune response.
Precisely. And the best part is there's zero risk of actually getting infected from the vaccine.
That's fantastic. How many doses of the hepatitis B vaccine are needed?
Typically, 3 doses are given over a period of time.
Okay.
And it's remarkably effective, over 90% effective in preventing infection.
Wow, that's impressive. Who should get the hepatitis B vaccine?
It's recommended for all infants and adolescents under 18 who haven't received it before. Also, people who are occupationally exposed to blood or body fluids, like healthcare workers, patients on dialysis, and travelers going to high-risk areas for extended periods.
So it's a pretty wide range of protection.
Yeah.
What about hepatitis C, D, and E? Are there vaccines for those?
Unfortunately, not yet. There's currently no vaccine for hepatitis C. Developing one has been a real challenge due to the virus's high mutation rate. It's like trying to hit a moving target.
Right, so the virus is constantly changing its disguise.
Exactly.
Makes it tough to develop a vaccine that can recognize and neutralize it.
Right.
Okay. As for hepatitis D, well, remember, it needs hepatitis B to survive, so
Yeah.
getting the hepatitis B vaccine indirectly protects you from hepatitis D as well.
Right, exactly.
Okay. And no vaccine for hepatitis E yet either.
Not yet, but research is ongoing.
Oh.
Scientists are constantly working on new ways to combat these viruses.
Okay. Let's move on to treatment then. What are the options for someone who's already infected with one of these hepatitis viruses?
So the approach really depends on the specific type of hepatitis and whether it's an acute or chronic infection. There's no one-size-fits-all solution here.
Okay. Let's take it virus by virus then. What about hepatitis A and E? Those are usually acute infections, right?
Right, exactly. And the good news is that hepatitis A and E are typically self-limiting, so they tend to run their course and clear up on their own without causing lasting damage. So treatment focuses on managing those uncomfortable symptoms like nausea, vomiting, and fatigue.
So it's a matter of riding it out and letting the body do its thing.
Pretty much. But of
Yeah.
course, if any complications arise, doctors will address those accordingly.
Right, okay. What about acute hepatitis B? How is that treated?
So, similar to hepatitis A and E, acute hepatitis B is often managed with what we call supportive care. So, antiviral medications are usually reserved for severe cases where there's a real risk of liver failure.
Okay, so it's a wait-and-see approach.
Right.
Only using the antivirals if absolutely necessary.
Exactly.
Okay, I see. So they try to avoid, unnecessary medication use.
Yeah.
Especially since some antivirals can have side effects.
Absolutely, yeah.
Right.
They want to weigh the potential benefits against the potential risks.
Makes sense.
Yeah.
What about chronic hepatitis B then? Is that when the antivirals come into play more aggressively?
Yes. So with chronic hepatitis B, antiviral therapy takes center stage. So the goal is to suppress the virus, prevent further damage to the liver, and reduce the risk of complications like cirrhosis and liver cancer.
And which antivirals are used for chronic hepatitis B?
So interferon alpha is a common choice, either the standard version or a long-acting form called pegylated interferon alpha.
Okay.
We'll get into more detail about interferon alpha and the other antiviral medications in a bit.
Okay. Sounds good. What about hepatitis C? How does treatment differ for acute versus chronic infection?
Okay, so for acute hepatitis C, doctors have two main options: pegylated interferon alpha or antiviral therapy.
So they have a choice right from the start.
They do, but here's an interesting twist. Treatment can actually be postponed for about 12 weeks to see if the virus clears on its own.
Oh, that's interesting. So there's a chance that the body might be able to fight it off without any intervention.
Exactly. Not everyone who gets infected with hepatitis C will develop a chronic infection. Some people's immune systems are able to clear the virus naturally.
Okay, that's good to know. What about when it does become chronic hepatitis C? What's the treatment strategy then?
So, antiviral therapy is also the cornerstone of treatment for chronic hepatitis C, but the specific medications used depend on the genotype of the virus.
Genotype, what does that mean?
Think of it like different strains of the virus. So, there are 6 main genotypes of hepatitis C, and each responds differently to certain medications. It's like having different keys for different locks. Doctors need to know which genotype they're dealing with to choose the right key, or in this case, the most effective treatment.
It's like personalized medicine again.
Exactly.
Tailoring the treatment to the specific virus.
Right. In the past, pegylated interferon alpha was commonly used for chronic hepatitis C, but newer and more effective antiviral therapies have largely taken its place.
Okay. We've talked a lot about these antiviral therapies.
Yeah.
Let's finally dive into the specifics.
Okay.
Starting with hepatitis B. What can you tell us about interferon alpha and how it works its magic?
Yeah. So interferon alpha is fascinating. It's a naturally occurring protein in the body that helps fight off viral infections.
Oh, wow. So we're essentially boosting the body's own defense system.
Exactly.
Okay.
And for medicinal purposes, we produce interferon alpha through recombinant DNA technology. It's like creating a synthetic version of the body's natural antiviral weapon.
That's pretty cool. But how does it actually work against the hepatitis B virus?
The exact mechanism isn't fully understood, but scientists believe that interferon alpha induces the production of certain enzymes in host cells that interfere with viral replication. It's like throwing a wrench in the virus's machinery, preventing it from making copies of itself.
So it's a powerful weapon against the virus.
Right.
What are the therapeutic uses of interferon alpha? We know it's used for chronic hepatitis B, but is it used for anything else?
Right, so peak interferon alpha 2A, which is a long-acting form of interferon alpha, is approved for treating chronic hepatitis B and was a key player in combination therapy for chronic hepatitis C in the past.
Oh, it's a versatile drug for sure.
It is.
Are there any downsides to using interferon alpha? Side effects, perhaps?
Unfortunately, yes. Interferon alpha can cause a range of side effects, the most common being flu-like symptoms like fever, chills, muscle aches, and fatigue. Some people also experience mental health issues, including depression.
So it's not a walk in the park. But I imagine the benefits outweigh the risks in many cases.
That's a decision that doctors and patients make together, carefully weighing the potential benefits against the potential side effects.
Okay, that makes sense. What other antiviral medications are used to treat hepatitis B?
Okay, so there are several others, including lamivudine, adefovir, and entecavir, each with its own mechanism of action and considerations.
Okay, so let's start with lamivudine. How does that one work?
Okay, so lamivudine is what we call a nucleoside analog. Picture it as a fake building block that tricks the virus's DNA polymerase, the enzyme responsible for copying its genetic material.
So it essentially sabotages the virus's ability to replicate.
Exactly. It throws a wrench into the copying process, preventing the virus from making more of itself.
Clever strategy. But I understand lamivudine is no longer recommended. Why is that?
Unfortunately, lamivudine has a high rate of resistance, so the virus can quickly adapt and figure out how to overcome its effects. It's like the virus outsmarts the medication.
Okay, so it becomes ineffective over time.
Yes.
What about adefovir? Is that still used?
Adefovir is a nucleotide analog similar to lamivudine, but with some key differences. It also inhibits the hepatitis B virus's reverse transcriptase enzyme, but it's less effective than other options.
Okay.
And it has a greater risk of causing kidney damage with long-term use.
So it's not ideal.
No, not ideal.
So it seems like lamivudine and adefovir have fallen out of favor.
Yeah.
That brings us to entecavir. What's the story with that antiviral?
Okay, so entecavir is another nucleoside analog that targets the hepatitis B virus's DNA polymerase, similar to lamivudine. But here's the key difference. Entecavir is effective against lamivudine-resistant strains of the virus.
So it's a backup option when lamivudine fails.
Precisely. And it has a good safety profile. The main caveat is that the dose needs to be adjusted for people with kidney problems.
Okay, so we've covered the main antiviral medications used for hepatitis B. Ready to tackle hepatitis C?
Let's do it.
Okay.
But before we dive into the specific medications, it's helpful to understand how the hepatitis C virus replicates.
Okay, walk us through it.
Okay, so think of the hepatitis C virus as this tiny, determined invader trying to take over a cell.
Okay.
It starts by attaching to the surface of a liver cell, called a hepatocyte, and injecting its genetic material, RNA, into the cell.
Oh, so it's like a hostile takeover.
Exactly. Once inside, the viral RNA hijacks the cell's machinery to make copies of itself, and it produces a long chain of viral proteins called a polyprotein.
So it's using the cell as a factory to produce more viruses.
Precisely. And this polyprotein then gets chopped up by cellular and viral proteases into individual proteins that are needed to build new viruses. Think of it like an assembly line, with each protein playing a specific role in the construction process.
So it's a coordinated attack,
Yes.
each step building towards the creation of new viruses.
Exactly. And the good news is that scientists have developed antiviral medications that target different steps in this replication process, effectively stopping the virus in its tracks.
That's amazing. So what are these different types of antiviral medications used to treat hepatitis C?
Okay, so let's start with the NS3-NS4A protease inhibitors.
Okay, what are those and how do they work?
Okay, so remember those proteases we talked about, the ones that chop up the viral polyprotein?
Yep.
Well, NS3-NS4A protease inhibitors block the action of these proteases, preventing the virus from producing the proteins it needs to replicate.
So they're like molecular scissors that snip the virus's lifeline.
That's a great way to visualize it.
Okay.
Examples of these inhibitors include paritaprevir, grazoprevir, glecaprevir, and voxilaprevir.
So it's a whole class of drugs with different names, but a similar mechanism of action.
Right.
Okay. Are there any downsides to using these protease inhibitors?
So they do have some limitations. They have a lower barrier to resistance compared to other antivirals, meaning the virus can more easily develop mutations that make the drugs ineffective.
Okay. So it's like a race against time with the virus constantly trying to outmaneuver the medication.
Yes. And they're metabolized by a liver enzyme called CYP3A, meaning they can interact with other medications that are also metabolized by this enzyme.
So doctors have to be careful about potential drug interactions there.
Yes.
Okay. What about side effects?
The most common side effects include rash, itching, nausea, fatigue, and anemia.
Okay, so they're not completely harmless.
Right.
Okay. What about the next class of drugs? What are NS5B polymerase inhibitors?
Okay, so NS5B polymerase inhibitors are another weapon in the fight against hepatitis C. Remember that NS5B polymerase is the enzyme responsible for copying the virus's RNA.
Yes.
Well, these inhibitors block that copying process.
So they're preventing the virus from making more copies of its genetic material?
Precisely.
Okay.
Examples of NS5B polymerase inhibitors include sofosbuvir, which is a nucleoside analog, and dasabuvir, which is a non-nucleoside analog.
So again, different drugs, same target.
Exactly. And the great thing about these inhibitors is that they're generally well tolerated with few side effects.
That's fantastic. Any potential drug interactions to be aware of?
Not as many as the protease inhibitors, but it's always important to check for potential interactions with other medications.
Of course.
Okay.
On to the next class. NS5A replication complex inhibitors.
Okay.
What are those all about?
So these inhibitors target a different part of the virus's replication machinery. So NS5A is a viral protein that plays a crucial role in assembling new virus particles.
Okay, so these inhibitors are disrupting the virus's assembly line,
Yes,
preventing those new viruses from being built.
exactly.
Okay.
And we have several examples of these inhibitors: latipasvir, ombitasvir, elbasvir, and daclitasphere, all with similar mechanisms of action but subtle differences in their chemical structures.
Okay, so again, different drugs, same target.
Right.
Okay.
Yeah.
Are there any downsides to using these inhibitors?
Like the protease inhibitors, they can interact with other medications that are metabolized by the liver's CYP450 enzymes.
So again, drug interactions are a potential concern.
Yes.
Anything else to watch out for?
There's an interesting caveat with latipasvir. It needs a low pH environment to work effectively.
Low pH. What does that mean in practical terms?
It means that if someone is taking a proton pump inhibitor, a common medication for heartburn and acid reflux, they should stop taking it if they're also on latipasvir. The PPI can raise the pH, making the latipasvir less effective.
Wow, that's a very specific interaction to be aware of.
Yeah.
Okay, so we've covered 3 classes of antiviral medications for hepatitis C.
Right?
What about ribavirin? I know that one's been around for a while.
Yeah. Ribavirin is an interesting drug. It's a guanosine analog, meaning it's a synthetic version of a naturally occurring molecule.
Okay. And how does it work to fight off hepatitis C?
That's the mystery.
No.
Despite its use for over 20 years, the exact mechanisms by which ribavirin works are still not fully understood.
Really? That's surprising. So we know what it does, but not exactly how it does it.
Yeah, it's like a puzzle that scientists are still trying to solve.
That's so fascinating.
Yeah. What we do know is that ribavirin is most effective when used in combination with other antiviral medications, either pegylated interferon alpha or direct-acting antivirals. It seems to enhance the effects of these other medications, improving viral clearance and reducing the risk of relapse.
So it's a team player,
It is.
boosting the effectiveness of the other medications.
Exactly. It's a valuable tool in the fight against hepatitis C, even if we don't have all the answers about how it works.
Okay, so we've covered a lot of ground on viral hepatitis. We talked about the different types, how they spread, the risk of complications, the importance of vaccination, and even the various treatment options available.
Yes.
It's clear that managing these infections requires a very nuanced approach, taking into account the specific virus, the stage of infection, and the individual's overall health. It's not a one-size-fits-all situation.
You hit the nail on the head. It's all about tailoring the treatment plan to each patient's unique circumstances.
Right. Before we wrap up this deep dive into viral hepatitis, there's one more topic Dr. Shorebuggy covers that we need to explore. Portal hypertension.
Okay.
What is portal hypertension, and how is it connected to viral hepatitis?
Portal hypertension is a serious condition that can develop as a complication of chronic liver disease, including chronic hepatitis B and C. So to understand it, we need to think about the liver's blood supply. Imagine a complex network of blood vessels delivering blood to and from the liver, keeping everything running smoothly.
Okay, so let's talk blood flow.
Yeah. The liver receives blood from two main sources: the hepatic artery, which carries oxygen-rich blood from the heart, and the portal vein, which carries nutrient-rich blood from the digestive system.
Okay, so the liver is getting a double dose of blood, one from the heart, one from the gut.
Exactly. And the portal vein is the key player in portal hypertension. So normally blood flows easily through the portal vein and into the liver, like a well-maintained highway. But in portal hypertension, something blocks or restricts that flow, causing pressure to build up in the portal vein. It's like a traffic jam in the liver's blood vessel.
Oh, that can't be good. So what kind of consequences does this traffic jam have?
Well, the increased pressure can force blood to find alternative routes back to the heart, bypassing the liver altogether. This can lead to the development of enlarged veins called varices in the esophagus, stomach, and rectum.
Varices. Are those dangerous?
They can be. Imagine those varices like weak spots in a tire. Under pressure, they can rupture and bleed. Esophageal varices, in particular, are prone to bleeding, and that can be life-threatening.
Oh, wow. That sounds incredibly scary. What other consequences can arise from portal hypertension?
Well, that increased pressure in the portal vein can also lead to a buildup of fluid in the abdomen. It's called ascites, and it can make someone look like they're carrying a watermelon under their shirt.
Wow, that's a vivid image. Anything else?
Portal hypertension can also cause enlargement of the spleen, known as hypersplenism. It's like the spleen is working overtime trying to filter all that backed up blood.
So it's a domino effect. One problem leading to a whole cascade of others.
Exactly. And it's important to understand that portal hypertension can be classified into three main types, depending on where the blockage is happening. We have prehepatic, intrahepatic, and posthepatic portal hypertension.
Okay, break those down for me.
Okay, so prehepatic portal hypertension means the blockage is happening before blood reaches the liver, often due to a blood clot in the portal vein.
Yeah.
Intrahepatic portal hypertension, this is the most common type, is caused by problems within the liver itself, like cirrhosis or fibrosis.
Okay.
And posthepatic portal hypertension means the blockage is located after blood leaves the liver, possibly due to a blood clot in the hepatic vein or even heart failure.
Okay, so depending on where the blockage is, you get a different type of portal hypertension.
Right.
And understanding the type helps guide treatment decisions.
Exactly.
So what can be done to manage portal hypertension?
The main goals are to lower the pressure in that portal vein and prevent complications, especially those potentially deadly variceal bleeds.
Right. So how do they do that?
You might be surprised to hear that beta blockers are the first-line treatment for portal hypertension.
Beta blockers. Aren't those usually prescribed for high blood pressure and heart conditions?
They are, but they also have this interesting effect of reducing blood flow to the liver, which in turn helps lower portal pressure.
Oh, so they're multitaskers.
You could say that.
Okay.
And in the case of portal hypertension, they're typically continued for life.
Wow, that's a long-term commitment. Which beta blockers are commonly used for portal hypertension?
Propranolol, nadolol, and timolol are all effective options.
What about other medications? Are there any other drugs that are used to manage portal hypertension?
Yes, doctors might use vasopressors, which are medications that constrict blood vessels to control bleeding from those fragile varices. It's like clamping down on those leaky blood vessels.
Okay, that makes sense. What are some examples of vasopressors?
So vasopressin is one option. It works by activating what are called V1 receptors on blood vessels, causing them to constrict and hopefully stop the bleeding. Dr. Shorebaggy also talks about somatostatin and octreotide in his lectures.
Okay, and what can you tell us about those?
Somatostatin and octreotide are also very good at controlling acute bleeding. Octreotide in particular is interesting because it can lower portal blood pressure by constricting the splanchnic artery, the one that supplies blood to the abdominal organs.
So it's like cutting off the fuel supply to the fire.
Precisely. By reducing blood flow to the abdominal organs, octreotide helps ease the pressure in the portal vein. Now, taking a step back from portal hypertension, we've covered a lot of ground today, from the nuances of pancreatitis to the complexities of viral hepatitis.
We have. And I have to say, Dr. Shorebaggy's lectures are packed with so much incredible information. It's clear he's passionate about pharmacology.
He is, and his enthusiasm is definitely contagious. I'm feeling inspired to delve even deeper into the world of drugs and their impact on human health.
Me too. As we wrap up this deep dive into the last of Dr. Shorebaggy's lectures, what are some key takeaways our listeners should remember?
Let's start with pancreatitis. We explored the two main types, acute and chronic. Remember that acute pancreatitis is a reversible emergency, while chronic pancreatitis leads to permanent damage.
And those causes of pancreatitis, I'm never going to forget the bad hits mnemonic.
It's a good one, isn't it? It really emphasizes just how diverse those causes can be, from gallstones and alcohol to certain medications and, of course, those scorpion stings.
Right. It's a good reminder that the pancreas is a delicate organ that can be affected by a wide range of things. What about treatment for pancreatitis? What are the main things to remember there?
For acute pancreatitis, it's all about supporting the body while it heals, reducing that inflammation, preventing infection, and addressing the root cause whenever possible.
And for chronic pancreatitis, the focus shifts to managing symptoms and preventing further damage.
Right. We talked about pain management, those artificial digestive enzymes that can be so helpful, insulin therapy if diabetes develops, and even steroids for those specific cases of autoimmune pancreatitis.
All right. Let's move on to viral hepatitis. What are the most important things to remember about those viruses?
Well, there are 5 main types, A, B, C, D, and E, each with its own way of spreading, its own incubation period, and its own risk profile for complications.
Hepatitis A and E spread through contaminated food and water, while B, C, and D are bloodborne. And the great news is we can be vaccinated against A and B.
That's right. And when it comes to treatment, it really depends on the specific virus and whether it's an acute or chronic infection. Sometimes supportive care is enough to get through the acute phase, while other times those antiviral medications are crucial to suppress the virus, prevent liver damage, and reduce the risk of long-term complications.
We explored a whole arsenal of antiviral medications, each with its own way of targeting the virus.
It can seem overwhelming, but the main takeaway is that there are effective treatments out there, and doctors can tailor the treatment plan to fit the individual and the virus they're battling.
And finally, we discussed portal hypertension, that serious complication that can develop from chronic liver disease.
Remember, it all comes down to increased pressure in the portal vein, which can lead to those varices we talked about, as well as ascites and hypersplenism.
Beta blockers are often the first line of defense, working alongside vasopressors to help control bleeding from varices.
That's right. So there you have it, a whirlwind tour through the world of pancreatitis, viral hepatitis, and portal hypertension. Dr. Shorebaggy has given us a lot to think about.
He has. I'm feeling incredibly grateful for all the knowledge he shared with us throughout this series.
Yeah, it really is amazing the amount of information that Dr. Shorebaggy has managed to pack into this whole series. I'm still buzzing from it all. But it's not just about the facts and figures, is it? You know, these conditions have real-world implications for people's lives.
Absolutely. And speaking of real-world implications, there's one more point Dr. Shorebaggy brings up that I think deserves a little further discussion.
Okay.
And that is liver transplantation for patients with end-stage liver disease due to chronic hepatitis. It's a heavy topic to be sure.
It is. Liver transplantation is a major undertaking, both for the donor and the recipient. It's not just a medical procedure. It raises a lot of complex ethical considerations.
Absolutely. For starters, there's the issue of organ scarcity. There simply aren't enough donor livers available to meet the demand. And it's a heartbreaking reality that forces us to make incredibly difficult decisions about who should be prioritized for transplantation.
It's like trying to solve an impossible equation, isn't it? How do you weigh the needs of one patient against another when every life is precious?
It's a heavy burden for the medical community to bear, for
Yeah.
sure. And what factors even go into that decision-making process? Like, how do they decide who gets a chance at a new liver and who doesn't?
It's a complex algorithm, a combination of objective medical data and, unfortunately, a bit of subjective judgment. So they're looking at the severity of the liver disease, the patient's overall health, their age, their social support system, and even their likelihood of adhering to the post-transplant treatment.
It's like trying to weigh all these different variables and come up with a system that feels fair and equitable.
Right.
Which I can only imagine feels impossible at times.
It's a constant struggle, for sure. And then, in addition to all of that, there are also the ethical considerations surrounding liver transplantation.
Living donor. You mean someone can donate a portion of their liver while they're still alive?
Exactly. The liver is an incredible organ, one of the few in the body that can actually regenerate. It can grow back to its original size even after a portion is removed.
That's amazing. It's like something out of a science fiction movie.
It is.
But I imagine there are some significant risks involved for the donor.
There are. It's major surgery, not to be taken lightly. There's the risk of complications, the long recovery period, and the potential long-term impact on their health.
Right. So it's a decision that shouldn't be made impulsively. It
Mhm.
requires very careful consideration and a deep understanding of the risks involved.
Absolutely. And on top of those medical risks, there's also the ethical question of whether it's right to ask someone to put their own health at risk for another person, even if that person is a loved one.
It's a profound question. What about the recipient's perspective? Are there any ethical considerations from their side?
Yeah, absolutely. There's the issue of adherence to post-transplant medication regimens. They have to be incredibly diligent about taking their anti-rejection medications, which, can have significant side effects and also be quite expensive.
So the lifelong commitment to staying healthy, protecting that incredible gift that they've been given.
Yeah, it's a huge responsibility. And then there's also the broader societal question of resource allocation for post-transplant care. Transplantation is a costly endeavor from the surgery itself to the long-term follow-up care. We need to make sure those resources are being used wisely and equitably.
Right. It's a complex web of interconnected issues.
Right.
Medical, ethical, societal, financial. It's not just about the science, it's about the human impact as well.
Exactly. And I think it just highlights the importance of open dialogue and ongoing reflection on these really complex issues. We need to keep asking tough questions, challenging assumptions, and advocating for solutions that prioritize both individual well-being and the responsible use of, these really precious resources.
Well said. This deep dive has definitely given me a lot to think about. It's been an incredible journey exploring the science behind these conditions, but also just the real-world challenges of managing them.
I agree. It's been a privilege to, dive into Dr. Shorbagy's lectures with you and uncover all this valuable information. And it's a great reminder that even though the series is ending, our learning journey never really stops.
That's so true. And to our listener, we hope you found this exploration of pancreatitis, viral hepatitis, and portal hypertension as fascinating as we have. Remember, knowledge is power. Keep asking questions, stay curious, and never stop learning.
Until next time, stay curious.